Good afternoon, everyone, and welcome to this very interesting panel. COVID has changed our medical world, and telemedicine has become an actuality, a reality we deal on a daily basis in our practice. I'm Dr. Kirill Micallef Stafrace. I'm a sport and exercise medicine consultant, and I was brutally introduced to telemedicine because of the lockdown in the country where we physically couldn't see our athletes, and we adapted to the best we could. We've got a very interesting panel with us today. I'll let each and everyone introduce themselves because their CV is too long and I didn't get my specs, so I can't read what I wrote anyway. So please, could you kindly introduce yourself and let's hear all we have to hear about you.
Thank you so much. Christopher Morris, general surgeon, bioethicist. I live in British Columbia, Canada, where my colleagues and I run a clinic called the Access Health Clinic, which is a rapid access surgical diagnostic and outpatient unit, which is largely telemedicine based.
Hi, I'm Malcolm Falzon. I'm a partner at Camilleri, Preziosi, a law firm based in Malta. My interests are mainly in commercial and M&A. However, I gained an interest in fintech over recent years, and with the onset of the pandemic, it led to inquiries in other areas which are tech-related. One of them related to telemedicine. Last year, I had the privilege of sitting on a panel with my fellow panelists here, and I learned a lot, and it's an area which I gained more interest in, and anyway, glad to be here and looking forward to the discussion.
Thank you for having us. My name is Victor Grech. I am a pediatrician and I run pediatric cardiology services for the country. I have several other interests. One of them is my How to Write a Scientific Paper course, and we'll talk about how that has evolved through COVID. And I've always been a firm proponent of telemedicine. I remember running a journal, and back in 1999, I actually asked someone to write a paper for me on telemedicine. Back in 1999. We just had our emails, I suppose, back then.
Well, that quite some way before the times then. Unless you lived in remote Canada or Australia, where I presume telemedicine was quite into. Do you have to use it because of the layout?
In Canada, we have two challenges. One is the geography. We have a very diffuse population. It's extremely difficult to co-locate physicians and especially specialist physicians and patients in remote areas. So telemedicine has been extant to some degree in Canada for at least 20 years. On top of that, we have issues related to access. And it's not uncommon for wait lists in Canada to achieve 2 or more years for some subspecialist services.
Wow. And yourself, you're involved in pain management, Chris?
I am, yeah. I do chronic pain and wounds.
Do you do telemedicine on that?
Yes.
How does it work out?
So when you're dealing with chronic wounds, obviously there's a lot more to the physical wound. There's the mental wound that goes with it. These people are often traumatized. They have chronic pain issues. And they need a much higher level of connectivity than a traditional structural clinic can provide to them. They need to have the ability to reach out and access the clinician, often at odd hours and rapidly, in the case of crisis management. And we found that rather than trying to bring everybody to us physically, that if we made ourselves available digitally, that it was a lot smoother for people. They were a lot more relaxed. They responded to us a lot better.
Well, the environment made it easier for them. They were in their own environment, I suppose.
Exactly, yeah. So a lot of telemedicine difficulties is related to patient expectations. And we've heard some of the other panelists discuss the difference between what a patient needs and what they want. But both of these things need to be satisfied. So we need to be prepared to understand what it is that a patient expects from us and provide it while in the background we're providing the care that they actually need. Right?
Okay, thanks. Victor, Tabib.mt, online education, you know, you can look at it, either it boomed or it was acts of desperation when COVID hit. Well, locally, and even with both the international aspect of it. How did you feel it went? Where could we have improved, moved forward from there?
Well, there was a spike in online consultations, obviously, and that's when Tabib took off. It'll proceed in some form or another. But we've been doing telemedicine now for ages. I mean, as of yesterday, I sent an echo study of a complex heart to Birmingham children for a second opinion at the drop of a hat. So we've been transferring huge data sets, echocardiograms, MRIs, CTs, what have you, all over the world.
But that's tertiary when you look for a second or third opinion, rather than having direct relation with a patient.
Face-to-face with patient, yes, we've had a lot of those. It's obviously waning now that people are more confident, people are going out. But I see that attitudes have changed. People are more willing to send you photographs. And being a pediatrician, some of the photos that are on my phone are disgusting. You know, the interiors of nappies, yeah, horrible stuff that they send me, and then they think this is okay, but this is life as a pediatrician. Vis-a-vis education, I've been running a course called WASP, Write a Scientific Paper, and I've been doing this since 2010. Accredited now, we've got CPD from the Royal College of Physicians as well, so that's a good thing. And what COVID has allowed me is something that was unthinkable before COVID. So one of the few silver linings, I now have a truly international faculty. So I have Jason Aberl, who does the ethics, he's a philosopher from the United States. I have two other speakers from the States. I have Suzanne Vosloo, who speaks from South Africa. So from all over Europe. So this is a truly international faculty. All I had to do was, you know, how to write a paper may sound difficult to the uninitiated, to the juniors. But to those of us who have done it and have been doing it for decades now, we can give many of the talks, except for the truly specialized ones like ethics, data protection. 𝐂𝐤𝐲, who was here this morning, gives the data protection talk, for example. So all I had to do was send a few emails out to colleagues of mine in pediatric cardiology and cardiac surgery, and I had a faculty overnight. And we also have an international following of delegates as well. So we do all the exercises online. I don't have to have an office anymore. I can't see myself going back. It is so convenient.
It's true, because, you know, we've all been involved in conferences, international conference. The mixed delegates and mixed presentations now is de rigueur. You do it. Next 5-6 conferences I've had lined up in the next month, there isn't a single one which is physically, just physical or just online. It's the mixed, and that's brilliant, I think. You get access to more speakers, which would never have come, especially with the travel implications that you have nowadays. Having a speaker from around the globe, physically present, digitally at least, I think enriches the conference and gives access to the delegates that previously didn't have anything. Malcolm, I didn't forget you, don't worry.
Yeah, don't worry.
Now, let's be honest. It's all fine and dandy. Say we do everything online, you stay home, you can do consultations in your underwear and no one's the wiser. That's fine. We all do it. Hopefully, we remember to keep the image on the right place. What are the legal implications, but where does that leave us from a medical legal point of view? Without showing the underwear. I mean, that's the problem. But.
Yeah, that's one set of problems, not an area of law I'm too specialized in. Just before getting on the regulatory, I just wanted to make a point on what was being mentioned earlier. Innovation is often the result of necessity, is born from necessity, and I think this is one very, very clear instance of that. I was at Sigma yesterday, the gaming and blockchain expo, and it felt as though, COVID hadn't happened and people were back to what they were at 2 or 3 years ago. And I think people do want to get back to the way things were before. Insofar as telemedicine is concerned, I think the drive that there needs to be is to reverse the trend that there was before. Vic mentioned, that telemedicine has been around for decades now, but in reality, how many of us considered, online consults to be the norm rather than the exception before the onset of the pandemic? And coming on to your question, Malta specifically, and that is where my expertise lies, or my experience, more expertise lies, has often looked at regulation as something beneficial or a means to stand out. Malta is a small country. It can react quickly and in a nimble way to circumstances, and often it has introduced regulation where there was a gap towards something. And coming to your question, one of the, I think, critical weaknesses when you come to telemedicine is the lack of a harmonized regulatory framework. We have an existing set of rules, those which apply to health, like your Health Act, obviously data protection, incredibly relevant in this realm. And then obviously there are your age-old considerations relating to civil law, the possible exposure to tort and claims made for in our case, medical malpractice or incorrect diagnosis and the like. So I think that the first drawback is the lack of perhaps harmonization and clarity. Insofar as the actual means or the medium which is being used to provide the service, or rather than face-to-face, but through an online medium, I think the data protection and privacy considerations are obviously those which come to mind most. There were lots of sessions this morning which really explained those risks, and yes, I think, without proper guidance, there is, you stand the risk of facing the monster that is, GDPR and the implications that arise there from. You are dealing with effectively the most sensitive and, to certain people, precious form of personal data, which without the necessary consents or derogations could land you in a quite a spot of trouble if used wrongly or even recklessly or negligently. And in some cases, the practitioner who would be, providing the advice to the patient with the patient's consent may suffer the consequences of the platform malfunctioning. I got involved in Tabib from a corporate perspective, advising the shareholders coming together, and that was, one of the first risks which I highlighted, the potential of the platform being suffering a cyber risk, for instance, and giving rise then, what are the implications on the practitioners themselves? So there's a number of legal, I think, considerations that would need to be made, which are identical to what you would face in normal face-to-face advice given to clients, and others which are of a different dimension purely because of the medium through which they are given.
Thanks. Chris, Canadian system of telemedicine. How does your medical indemnity cover you for any issue on those lines?
So we're completely covered. So we've had a fee code for telemedicine for many years. And the government responded very rapidly to the COVID crisis and opened up a lot of existing limitations for billing and for indemnity in the sort of COVID era.
So your insurer would cover?
Yes, fully covered.
Okay. How is it locally, Victor?
I'm not quite sure how it's covered locally. You said harmonization etc. I suppose before COVID, people would call you, before mobiles. Yes, we are that old. Before mobiles, people would call you and you could have a consultation on the phone. With smartphones, they started to send pictures. And it's like a conversation and a consultation on the phone. Are we indemnified for that if something blows up in your face?
But Tabib, for example, you charge, while
Yes.
for these you didn't.
Yes.
So
But I don't think the law is cognizant of that fact.
Yeah, that's a perfect example of where the law has not caught up with innovation. There are rules under subsidiary legislation under the Health Act which relate to professional indemnity insurance. There is obviously the obligation of every medical practitioner to have that kind of insurance. But does it cover you for providing advice online when perhaps careful thing to do, or sorry, the thing you should have done if exercising the proper duty of care would have been to actually insist on visiting the patient in person? I mean, Chris and Victor will tell me, but I suppose that there is a point at which I think you would realize that telemedicine is just simply not suitable. It's not the right medium. So I believe that when early in COVID, I think there was the medical council which had actually advised its members to say, listen, the use of telemedicine is all well and good. You're doing the right thing and rendering a service to people who physically cannot get to you or to your clinic. But be extremely careful in dispensing that advice, because there are certain things which you will simply not be able to diagnose properly or be able to see across a screen of your phone, your iPad, whatever it is. So yeah, and then obviously there are certain risks, like cyber risk we mentioned, or the incorrect use of data, which may simply just fall beyond the remit of your cover.
I agree completely. I think it's a question, as physicians, of common sense. Some things can be done. I mean, I guess dermatology, most of it could be done online. Let's face it. Surgery is going to be difficult to do online. Pediatrics is maybe hybrid.
Sports medicine is a question mark.
Difficult.
Yeah.
But I think it's a question of common sense as well. You can be caught out, probably, even with common sense, but
I consult to the company that offers occupational health services, sick leave verification. They've been for the last 18 months doing everything digitally. But the companies want to revert to physical visits. And the reality is common sense. I mean, I think really it's common sense. When, especially in pain management, where you have a multidisciplinary team usually involved, where do you draw the line and say, listen, we've reached a point, that's the maximum we can get online, or we need an adjunct which is physical, they have to get physically seen. Where do you take the decision, or how do you take the decision? Or does the patient take the decision sometimes?
Both. I think the real answer is that we individualize for patients and their needs. I think collectively we're talking about the standard of care as we are pulled out of the grand narrative of modernist medicine into this new postmodernist paradigm that we hardly understand and yet find ourselves in the middle of. And the patient expectations of us are changing. So we talk about having phone calls or video calls with patients. We talk about sending photos. But there's much more going on than that, I assure you. The patient that you're talking to has checked your credentials online, has checked the credentials of your colleagues online, has looked at what's available globally, and has looked at a much broader standard of care than you may be aware of, and has also been exposed to Dr. Google, understands a lot more about their condition than you might know, and is having a much more professional discussion with you in a lot of cases than you may be aware of, and this may open up whole new avenues of legal issues regarding the standard of care.
Yeah, undoubtedly, I think frankly, patients in the medical sphere or clients in general have become, I think, more educated. No, I think education is something which over time in multiple areas has evolved. Now, whether Dr. Google is dishing out the right education is another thing, obviously. But I think you still have instances in which I think for the practitioner it becomes abundantly clear quite early in the on a call or a video call that the patient is either unable to express exactly what or correctly what symptoms he or she is feeling, or has almost already formulated a view in his or her mind, and you almost sense that whatever you are going to say is going to be questioned or second guessed on the basis of information which is out there. So again, in that case, I mean, frankly, I would exercise common sense and know when to say, okay, now I think it's time for to move on to a different medium, which is perhaps what you were previously accustomed to.
And to round up, technology is ridiculously advancing at a pace we're hardly managing to keep up. And nowadays our smartphones give you health information. Where do we see that from diagnostics in telemedicine, that the smartphones can check your blood glucose, can check your hemoglobin, can give you these parameters? Would you be comfortable having your patient giving you this data and forwarding it to you and working on that data?
Do you have a choice?
Well, they could still physically come and see you sometimes, you know.
Yes, but they will do it. They'll send you a spreadsheet with their blood pressures. They'll send you a spreadsheet with their saturation. Do you have an option?
Agreed. But you can also counsel the patients on what you expect from them in terms of the information that they can provide you. And there are a number of off-the-shelf tools that allow them to communicate with you better, right? And we have a tendency to ignore a lot of the information that's out there and available to us. And as we evolve to fill the role of the telemedicine physician, I think that we'll communicate better.
And education. I believe we have to educate ourselves better on what's available, but we also have to educate our own patients on the best way to communicate the information they have to us.
We need to be humble as well, because Dr. Google, and not Dr. Google, if they're clever, say someone with a rare disease, they will go on OMIM, National Library of Medicine, and believe me, they will know more than you about the topic. Has happened to you? Has happened to you? So we have to be a bit humble as well, and accept what they know.
And it should be happening, right? Patients will ultimately emancipate themselves from paternalist medicine paradigms, right?
Thank you very much. We all learned from that, and let's go and have a friendly chat after. Thank you.
Thank you.
Round of applause,
Thank you.
please. Thanks.